So now we're going to talk about psychosocial nursing. This lecture is kind of a combination of chapters 42, 43, 46, and 47. So it's kind of a long one, but it's all four of these chapters combined. First thing is we're going to talk about self-concept. Self-concept or self-image is crucial to a person's health and well-being throughout life. A person's self-concept, which is the mental image or picture of self, has the power to either encourage or blunt a personal growth. Several variables contribute to self-concept. Think back to Maslow's hierarchy of needs, and as a person meets the needs of the lower levels, the needs for self-esteem and self-actualization start to come to the fore. The need for self-esteem is the need that people have to feel good about themselves and to believe that others hold them in high regard. The need for self-actualization is the need for people to reach their full potential through development of their unique capabilities. Disturbances in self-concept may occur for a number of reasons. Identity diffusion is the failure to integrate various childhood identifications into a harmonious adult psychosocial identity, which can lead to disruptions in relationships and problems of intimacy. Depersonalization is a person's subjective experience of the partial or total disruption of the ego and the disintegration or disorganization of self-concept. There are several theorists that discuss the formation of self-concept. In a nutshell, the formation of self-concepts includes the following. An infant learns that the physical self is different from the environment. If basic needs are met, warmth and affection are experienced, and the caregiver's anxiety is minimized, then the child begins life with positive feelings about self. The child next internalizes other people's attitudes towards self, including attitudes directed towards the child's innate tendencies, such as temperament and aggression. This internalization forms the foundation of self-concept. Parents or other direct caregivers play the most influential role. Peers play the second most influential role. Later, the child continues to behave in ways that confirms this early self-concept. How loved you felt as a child is a great predictor of how you manage all sorts of difficult situations later in life. The child or adult ends up internalizing the standards of society. Stages in the development of self include self-awareness, which develops as an infant. Self-recognition starts showing up about 18 months. Then self-definition around 3 years of age, and self-concept 6 to 7 years old. Psychological conditions that foster healthy development of self in children include some of the following. So if the child experiences warmth and acceptance and has effective structure and discipline, the child having clearly defined standards and limits so that children understand what goals, procedures, and conduct are approved in their society. Having adequately defined roles for both older and younger members of the family. Having established methods of handling children that produce the desired behavior, discourage misbehavior, and deal with infractions when they occur. So discipline. Encouragement of competence and self-confidence by caregivers, helping children meet challenges, having appropriate role models, and having a stimulating and responsive environment. So there are several factors that can affect self-concept, and we're going to talk about each of these in detail in the following slides. We've kind of talked about some developmental considerations already, but as a person matures, the criteria that mark the experience necessary for a positive self-concept change. Although the infant needs a supportive environment in which all human needs are met, the growing child needs the freedom to explore and develop the ability to meet increasing personal needs. Adults generally view inadequacies and faults less as a confirmation of incompetence and see them more as difficulties common to all people. As a child internalizes the value of parents and peers, culture begins to influence a sense of self. If the culture is relatively stable, little tension may be experienced between what culture expects of the child and what the child expects of themselves. When parents, peers, and the adult world confront the child with different cultural expectations, however, the sense of self may become confused. For example, an adolescent might realize their parents live by the work ethic and believe it is necessary to rise early every day and put in a full day's work. The adolescent's peer group, however, has few demands placed on it and encourages the adolescent to hang out with the group. Children of immigrants whose values and practices of their culture of origin vary from the culture of adoption face cultural dissonance. Parents may expect children to behave according to their own cultural norms, where peers in society, as well as the adolescent's wish to belong, may create the desire to abandon old cultural beliefs, attitudes, and practices. Conflict between parents and children, as well as cultural confusion, can occur with this. So when we talk about internal and external resources, think of internal resources as personal strength. Your book gives an example of one person may use humor as both an effective coping mechanism and a successful interpersonal tool. Another person may use humor to avoid facing conflict, but may feel badly about being known as a joker or a clown. The degree to which a person integrates healthy, useful internal resources or personal strengths is associated with how well a person has been able to establish a positive self-concept. Self-concept is also associated with the ability to identify and use external resources, such as a network of support people, adequate finances, and organizational supports. People who feel more positive about themselves tend to feel connected to others and to society. They can identify and use more external resources. People who feel disconnected and alone tend to perceive and use fewer environmental resources. A past history of success or failure is a big factor when it comes to self-concept. A history of success contributes to a positive self-concept. Multiple experiences resulting in success encourages a person to seek out new challenges, especially if a person has a strong support system. History of failure contributes to a negative self-concept. Multiple experiences of failure result in defeat and may predispose a person to expect failure in the future or even to avoid opportunities for growth because of the fear of failure. Life stressors or crises, and this can include things like marriage, divorce, acute or chronic illness, an exam, a new job, or job loss, may call forth a personal response and mobilize a person's talents, resulting in good feelings about oneself, or it might result in emotional paralysis with diminished self-concept. People vary greatly in their perception of what constitutes a crisis or stressor, as well as to the degree to which such experiences disrupt or diminish their self-concept. How the person perceives the stressor, is it a threat, a challenge, or a defeat, and the person's ability to mobilize personal strengths and other resources are determined largely by that person's self-concept, which in turn is influenced by the response the person chooses. The United States is a youth-oriented society in which physical attractiveness, vitality, health, and youth are valued. Body disfigurement, chronic disease, loss of a body part, and wrinkles, loss of hair, and other signs of aging may pose a serious threat to certain people's self-concepts. There are several areas we need to look at when we're assessing a person's self-concept. This includes self-esteem, body image, personal identity, personal strengths, and role performance. Self-esteem is judgment of one's own worth. It may reflect a personal admiration or respect for self. This can be in relation to the totality of the whole self or certain parts of self. So they might admire their appearance, their intellect, or their accomplishments. It may also be based on one's view of the self in relation to personal standards or standards set by others. This can also be influenced by how others view the patient. The thing with assessing body image is that we have to keep in mind that it's a subjective mental image of one's physical appearance and functioning. And body image can also be altered by a loss. So this could be a loss of a body part or function, disfigurement, or developmental changes. A person's body image can change over time. It'll change over time in response to alterations in one's physical appearance and functioning. A change in the body can negatively affect a person's self-concept, health, and health-seeking behaviors. Sudden changes in the body, such as a paraplegia or an amputation of an extremity, generally is more traumatic than gradual changes in the body associated with aging. And change in the body's appearance or function may precipitate denial, anger, despair, or depression. depending on the patient's coping mechanism. Personal identity is a person's view of self as a unique, separate, and distinct individual. It can be influenced by culture and socialization. This begins in childhood when a person identifies with parents and extended family members, and then by teachers, friends, and other people with whom the person comes into contact with. Personal identity remains relatively stable over time. When we think of characteristics of a person with a strong personal identity, it's a person that values their own viewpoints, perceptions, and contributions. And when faced with a crisis, they are more likely to work hard to address the challenge. In contrast, characteristics of a person with a weak personal identity may not value their own viewpoints and perceptions or view contributions in a positive frame of reference. This type of person is more likely to compare themselves with others and be influenced by others, and when faced with a crisis, they are more likely to limit their activities or blame illness or disability on others. Personal strengths are components within a person that one draws upon to manage stressful situations in life, such as a positive mental attitude, talents, pride in life achievements, and positive coping skills. These can be drawn upon by patients to help manage stress. Throughout life, people are expected to engage in roles, such as child, parent, spouse, sibling, grandparent, employee, and so on. People tend to view themselves in light of the roles that they are expected to fulfill and whether they can fulfill them successfully. There are certain challenges to a person's ability to meet role expectations. Health challenges and developmental changes due to aging can affect how successfully one is able to meet role expectations. Role changes in life also require transition. This transition can be situational, such as the death of a spouse or child, divorce, job termination, and relocation. It can also be developmental, such as commencement of a career, marriage, parenthood, retirement, and so on. People with strong self-concepts do better with changes in roles. People with a strong self-concept are better able to draw upon personal strengths to adjust to the changes in roles than people with a weak self-concept. A person's self-concept can be challenged or negatively impacted by health problems such as illness, disability, and disfigurement. These patients may not have personal strengths to manage change in a positive way, or these patients may react with ineffective coping such as anger, depression, and even suicide. However, a person's self-concept can be improved through nursing interventions. Interventions that help a patient to view oneself more positively, use positive strategies to improve relationships with others, employ more effective and positive coping strategy, and accept a change or deterioration in their health or quality of life are going to be best to help a person's self-concept. When confronted with a major stressor, many people forget that they have histories of successful coping and numerous personal strengths. Patients at high risk for giving up are those with low self-esteem or multiple stressors that they perceive as overwhelming. Patients experiencing powerlessness may need help to recognize their strengths. Examples of personal strengths that might better equip a person to respond to life's challenges include a healthy functioning body, the ability to adjust or to function with chronic bodily malfunctions, good cognitive abilities, positive self-concept, interpersonal skills, and a sense of meaning and purpose in life. Specific strategies that can be used to help patients identify and use personal strengths include encouraging patients to identify their strengths, replacing self-negation with positive thinking, noticing and reinforcing patients' strengths, encouraging patients to will for themselves the strengths they desire and try and use them, and then help patients to cope with necessary dependency resulting from aging or illness. People who are acutely ill are often separated not only from their strengths, but also from any real sense of self. This occurs largely because as patients in healthcare facilities, they are removed from their personal roles, environments, and belongings, and are stripped of their individuality by staff caring for them. Some ways to help patients maintain a sense of self while being cared for include communicating worth with looks, speech, and judicious touch, acknowledging the patient's status, role, and individuality, speaking with the patient respectfully, and again, address them by their preferred names. So ask them, what do you want me to call you? Do you want me to call you by your first name or Mr. or Mrs.? We want to converse with the patient about their life experiences and offer simple explanations for procedures. Move the patient's body respectfully if necessary. Respect the patient's privacy and sensibilities, and acknowledge and allow expression of negative feelings. And lastly, help the patient recognize strength and explore alternatives. Always keep in mind that patients are people first and foremost. A person's illness does not define who that person is. Too often, healthcare professionals tend to focus primarily on the patient's illness, and the whole person is forgotten or ignored, with potential negative consequences for that patient's sense of self, such as a lack of motivation to learn or execute important healthcare behaviors. The way nurses care for patients can directly affect self-concept. Self-concept in turn directly affects health. So now we're going to talk about stress and adaptation. The experience of stress and the responses to it are unique to each person. The process of responding to stress is constant and dynamic and is essential to a person's physical, emotional, and social well-being. Stress is a major factor in health and illness. Nurses need to understand the concept and levels of stress when providing nursing care to patients in all settings. Nurses themselves are subject to stress from the demands of their career and need to know healthy ways of responding. Stress is a condition in which the human system responds to changes in its normal balanced state. Stress results from a change in a person's internal or external environment that is perceived as a challenge, a threat, or a danger. A stressor is anything that is perceived as challenging, threatening, or demanding that triggers a stress reaction. Stressors may be internal. This can include illness or hormonal change or fear, or external, loud noises, cold temperatures, death of a spouse, relocation, anything like that. Stressors can be physiologic or psychosocial. A physiologic stressor may cause psychosocial stress and vice versa. Physiologic stressors have both a specific effect and a general effect. The specific effect is an alteration of normal body structure and function. The general effect is the stress response. Primary physiologic stressors include chemical agents like drugs and poisons, physical agents, which include heat, cold, and trauma, infectious agents like viruses and bacteria, nutritional imbalances, hypoxia, and genetic or immune disorders. There are almost an infinite variety of psychosocial stressors. Some of the examples are on this slide. First one would be accidents, which cause stress for the victim, the person who caused the accident, and families of both. You can have stressful or traumatic experiences of family members and friends. Horrors of history. This includes stuff like Nazi concentration camps, the dropping of the atomic bomb on Hiroshima, September 11th in the United States, or the Orlando Pulse nightclub shooting, or any school shooting for that matter. Another one would be fear of aggression or mutilation. This includes muggings, rape, shootings, and terrorism. Events of history that are brought into our homes through television and internet, such as wars, earthquakes, violence in schools, and civil unrest. Rapid changes in the world and the way we live. This includes changes in the economic and political structures, rapid advances in technology, and shifts in values and priorities. And then we have the inherent stressors, social isolation, political divides, change in work-life separation, and public health crises brought on by the COVID-19 pandemic that began back in 2020. We're still feeling the psychosocial effects of that. To maintain health, the body's internal environment must remain in a balanced state. Various physiologic mechanisms within the body respond to internal changes to maintain homeostasis, which is a relative constancy in the internal environment. The concept of homeostasis has been expanded to include both physiologic and psychological balance. The general adaptation syndrome is a biochemical model of stress developed by Sully back in 1976. The GAS describes the body's general response to stress, a concept that impacts all facets of nursing care. The 3 stages in the GAS are alarm reaction, stage of resistance, and stage of exhaustion. Although the alarm stage is short-term, which can last anywhere from minutes to hours, the length of the resistance and exhaustion stages vary greatly, depending on such variables as the severity and duration of the stressor, the person's previous health and coping mechanisms, and the immediacy and effectiveness of healthcare interventions. In the alarm reaction stage, alarm is initiated when a person perceives a specific stressor and various defense mechanisms are activated. The sympathetic nervous system initiates the fight or flight response, preparing the body to either fight off the stressor or to run away from it. This phase of the alarm reaction, called the shock phase, is characterized by an increase in energy levels, increase in oxygen intake, increased cardiac output, increased blood pressure, and mental alertness. During the second phase of the alarm reaction, countershock, there is a reversal of these body changes. The stage of resistance is basically an adaptation stage. Having perceived the threat and mobilized its resources, the body now attempts to adapt to the stressor. Vital signs, hormone changes, and energy production return to normal. If the stress can be managed or confined to a small area, the body regains homeostasis. If the stressor is prolonged or strong enough to overwhelm the body's ability to defend itself, and this would be the case of like a severe injury and bleeding or a major illness like cancer or a heart attack, then the adaptive mechanisms become exhausted. In the stage of exhaustion, exhaustion results when the adaptive mechanisms can no longer provide defense. This depletion of resources results in damage to the body in the form of wear and tear or systemic damage. Without defense against the stressor, the body may either rest and mobilize its defenses to return to normal or reach total exhaustion and die. To maintain mental well-being, humans must maintain a psychological homeostasis as well. Remember that every person needs to feel loved and a sense of belonging, to feel safe and secure, and to have self-esteem. When these needs are not met or a threat to need fulfillment occurs, homeostatic measures in the form of coping or defense mechanisms help to return the person to an emotional balance. Your book gives a very applicable example of the mind-body interaction involved with stress. All right, so picture this. Tomorrow you are scheduled to take a final exam and you must earn a passing score to pass the course and remain in the nursing program. After being awake most of the night, you cannot swallow any food at breakfast, you have a rapid heartbeat, you are filled with feelings of apprehension, and you have diarrhea. As you begin the test, you discover that you do know most of the answers. Your stress decreases and your symptoms disappear rapidly. Although not well understood, it is thought that humans react to threats of danger as if they were physiologic threats. A person perceives the threat on an emotional level, and the body prepares itself either to resist the danger or to run away from it. That's that fight or flight response. Each person reacts in their own way to prolonged stress. Some may develop chronic diarrhea, while others may develop nausea or heart palpitations. Such illnesses are real and are called psychosomatic disorders because the physiologic alterations are thought to be at least partially caused by psychological influences. Anxiety is a feeling of uneasiness and apprehension that occurs in response to a nonspecific, vague threat to the patient's physical, emotional, or social integrity that activates the autonomic nervous system. Anxiety can range anywhere from mild to severe. With mild to moderate stress, this can support motivation and may actually encourage a person to take positive action. So mild to moderate anxiety actually can be a good thing. And it makes you more on point, makes you more focused, and you can actually get some things done. However, if you progress on to severe anxiety, this can interfere with a person's ability to focus and communicate, causes one to be easily distracted, and increases motor activity and consumes energy because all behavior is directed towards seeking relief. And then even a step beyond severe anxiety is panic. Panic causes the person to lose control and experience dread and terror. The resulting disorganized state is characterized by increased physical activity, distorted perception of events, and loss of rational thought. The person is unable to learn, concentrates only on the present situation, and often experiences feelings of impending doom. This level of anxiety can lead to exhaustion and death if it's not resolved. So coping mechanisms are behaviors used to decrease stress and anxiety. Many coping behaviors are learned based on a person's family, past experiences, and sociocultural influences and expectations. As illustrated in the list on the slide, coping behaviors may be positive or negative in terms of how they affect health. Typical coping behaviors include crying, laughing, sleeping, cursing, using physical activity or exercise, taking deep breaths, mindfulness exercises, smoking or drinking, a lack of eye contact or withdrawal, or limiting relationships to those with similar values or interests. Defense mechanisms are other unconscious reaction to stressors. These mechanisms protect a person's self-esteem and are useful in mild to moderate anxiety. When extreme, however, they distort reality and create problems with relationships. At that point, the mechanisms become maladaptive instead of adaptive. I have a handout in Brightspace that describes all of these defense mechanisms for you. Physiologic and psychological stress affects all dimensions of a person. Stress strongly influences how a person attains basic human needs. It is a factor in health and illness, and it is a component in family reactions to illness. Meeting basic needs and adapting to stress requires energy and intentional action. As a person strives to meet basic human needs at each level, stress can either be a stimulus or a barrier. Action to achieve balance are individualized and depend on the person's sociocultural background, priorities, and past experiences. In all people, the failure to meet needs results in an imbalance in homeostatic mechanisms and eventually illness. Stress in a healthy person may promote health and prevent illness. However, for example, the fear of developing lung cancer may motivate a person to stop smoking, or anxiety about baby care may prompt prospective parents to attend prenatal classes and read childcare books. The effects of stress on a sick or injured person are, in contrast, usually negative. Stress can make an illness worse, and illness can cause stress. The presence of an illness or a disability demands new coping skills at a time when homeostasis is challenged. People who enter healthcare settings as patients are also subjected to situational stressors. Long-term stress poses a serious threat to physical and emotional health. As the duration, intensity, or number of stressors increases, a person's ability to adapt is lessened. The failure of adaptive mechanisms is also influenced by a person's state of health and past experiences with stress. Long-term stress affects physical status, increasing the risk of disease or injury. Recovery and return to normal functions are also compromised. High levels of ongoing stress are associated with multiple health disorders. Alcohol and drug abuse, depression, suicide, accidents, and eating disorders have also been associated with chronic stress. The stress that affects an ill person also affects the person's family members and significant others. When the family is viewed as a system, the behavior of the individual is influenced by family, and any alterations in the individual's behavior affects the family. Stressors for the family include changes in family structure and roles, anger and feelings of helplessness and guilt, loss of control over normal routines, and concern for financial stability. Caring for a family member at home for long periods can also cause prolonged stress. This stress response, called caregiver burden or caregiver stress, includes chronic fatigue, sleep problems, and an increased incidence of stress-related illnesses, such as high blood pressure and heart disease. Prolonged stress can seriously threaten mental health. A crisis is a disturbance caused by a precipitating event, such as a perceived loss, a threat of loss, or a challenge that is interpreted as a threat to self. In a crisis, the person's usual methods of coping are ineffective. This failure produces high levels of anxiety, disorganized behavior, and an inability to function adequately. Crises may be maturational, situational, or adventitious. Maturational crises occur during developmental events that require a role change, such as when a teenager transitions into adulthood. Situational crises occur when a life event disrupts a person's psychological equilibrium, such as a loss of a job or a death of a loved family member. Adventitious crises include accidental and unexpected events resulting in multiple losses and a major environmental changes, such as fires, earthquakes, and floods, that involve not only individuals but entire communities. Nursing involves activities and interpersonal relationships that are often stressful. Activities and situations identified as highly stressful include some of these on the slide. And this would be assuming responsibilities for which one's not prepared, working with unqualified or insufficient number of personnel, working in an environment in which supervisors and administrators are not supportive, experiencing conflict with a peer or other member of the interprofessional team, caring for a patient who is suffering while also supporting the patient's family, caring for a patient during a cardiac arrest or for a patient who's dying, providing care for a patient who's disfigured, non-adherent, or lacks the resources to participate in their care. And lastly, knowing the correct, right, or ethical course of action in a situation, but being unable to take that action. So you'll end up in this is called moral distress. This kind of stress is even greater for two specific groups of nurses: new graduates who must adjust to an environment and a role different from that experienced as students, and nurses who work in settings such as the intensive care unit or in the emergency room. Nurses may use a variety of interventions to help patients decrease stress and to facilitate coping. Methods should be selected carefully based on the person's physical and emotional characteristics, family and social structure, and previously used successful coping mechanisms. One of those is teaching healthy activities of daily living. A person's usual lifestyle greatly influences that person's perception of and reactions to stressors. Exercise, rest, and good nutrition are important components of stress reduction. So it follows that a person who is overweight, sedentary, and chronically sleep deprived is at increased risk for developing an illness as a result of stress. Regular exercise helps maintain physical and emotional health. The benefits of exercise include an improved musculoskeletal system, more effective cardiovascular function, weight control, and relaxation. Exercise improves a person's general sense of well-being, relieves tension, and enables coping with day-to-day stressors. Rest and sleep help the body maintain homeostasis and restore energy levels. Adequate rest can provide insulation against stress, but stress may interfere with a person's ability to sleep. Each person has individual sleep needs, but generally 7 to 9 hours of sleep a day is the usual recommendation. Relaxation techniques can be used during both health and illness to facilitate rest and sleep. Hospitalized patients may require additional nursing interventions to relieve pain and promote comfort to get needed rest. Overeating food that is not nutrient dense, severely limiting intake, and craving a specific food are common and often negative coping strategies that need to be considered when addressing stress and coping mechanisms. Nutrition plays an active role in maintaining the body's homeostatic mechanisms and in increasing resistance to stress. Lastly, families and support groups provide emotional support that can help a person identify and verbalize feelings associated with stress. In addition, families and support groups provide an accepting environment, allowing the person to explore problem-solving methods and try out new coping skills. Support groups, aside from providing information and services, may help a person maintain a positive self-concept and establish an avenue for new relationships and social roles. Another stress management intervention is teaching and encouraging stress management techniques. Stress creates emotional distress that often produces physical signs and symptoms. One person may have a tension headache, another may become irritable, and yet another may clench both fists. Some people take legal and illegal drugs, smoke, drink to excess, or eat compulsively. These behaviors can be modified, and adaptive mechanisms can be strengthened through specific techniques aimed at managing stress. Relaxation techniques are useful in many situations, such as childbirth, pain, anxiety, sleeplessness, illness, and anger. Relaxation promotes a body reaction opposite to that of the fight or flight response. Respiratory pulse and metabolic rates, as well as blood pressure and energy use, can all be decreased using relaxation methods. Mindfulness practice has been widely implemented in healthcare in the past few years. Mindfulness requires intentional presence and focus on the moment. Curiosity, openness, and acceptance without judgment support the centering. Meditation and breathing exercises may be used to support the mindfulness practice. Psychological and physical benefits include stress and anxiety reduction, improvement in cardiovascular and immune health, and increases in energy, concentration, and creativity. Mindfulness practices may positively impact nurses by decreasing their stress, anxiety, depression, and burnout while increasing their well-being and capacity for empathy. Anticipatory guidance focuses on psychologically preparing a person for an unfamiliar or painful event. Nurses use this technique when they teach patients about procedures in the surgical experience. When patients know what to expect, their anxiety is reduced and their coping mechanisms are more effective. For example, before performing a painful procedure, such as ambulating for the first time after surgery, teaching would include information about the pain involved, including onset, severity, cause, and methods of relief. With this knowledge, the patient feels less threatened and tolerates the procedure more easily. In guided imagery, a person creates a mental image, concentrates on the image, and becomes less responsive to other stimuli, including pain. The nurse sits by the patient and reads a description of a scene or an experience that the patient has described as a happy, pleasant, and peaceful. The patient is then guided through the image. So, for example, using a soothing, soft voice, the nurse might start like this. You are floating in your swimming pool. The water is cool and comfortable. Birds are singing in the trees. The roses are perfuming the air. As the patient becomes more and more focused on the scene, the nurse needs only to verbally paint a picture at intervals. A crisis is a situation that cannot be resolved by usual coping mechanisms. As a result, the person can't function normally and requires interventions to regain equilibrium. Crisis intervention is a short-term management technique focused on reducing damage to an individual or group affected by a crisis, often a mental or medical health emergency. Although there are several models of crisis intervention and the contextual elements of the crisis needs to be considered, the SAFER model is often used as a beginning framework for individual crisis intervention. With the SAFER model, we start out with S, which means stabilization. With stabilization, you're going to introduce yourself and establish your role and that of the other people involved. We want to meet basic needs, including safety of everybody involved, and mitigate any acute stressors if possible. Next step is A, for acknowledgement. Acknowledge the precipitating event and the reactions of the individual. Next is facilitation, F, facilitation of understanding. Paraphrase and reflect back to the individual what they are experiencing. Normalize their reaction to a stressful event and work to minimize feelings of personal weakness. Next step is E, encourage effective coping. Tap into their existing coping tools and resources and identify external resources of support to facilitate coping. First R is recovery. We're going to assess and establish the patient's ability to function safely. Second R is referral. Make referrals as needed. So this is about as far as I'm going to go with crisis intervention. You're going to talk more about crisis intervention in depth when you get to your mental health course later on in the program. So now we're going to talk about sexuality. A critical component of human identity and well-being, sexuality encompasses biological sex or sex assigned at birth, sexual activity, gender identities and roles, and sexual orientation. It involves how a person both exhibits and experiences sexuality physically, emotionally, and mentally. One definition of sexuality is the behavioral expression of sexual identity. Sexuality includes learned behaviors that affect how people respond to their own sexuality and how they behave in relationships with others. Cultural, biological, socio-political, legal, economic, religious, spiritual, and historical factors influence sexuality. Sexual health represents the integration of the somatic, emotional, intellectual, and social aspects of sexual being in ways that are positively enriching and that enhance personality, communication, and love. The World Health Organization identifies the following critical elements of positive, holistic sexual health. Sexual health is about well-being, not merely the absence of disease. It involves respect, safety, and freedom from discrimination and violence. It depends on the fulfillment of certain human rights. It is relevant throughout the individual's lifespan, not only to those in the reproductive years, but also to both the young and the elderly. It is expressed through diverse sexualities and forms of sexual expression. It is critically influenced by gender norms, roles, expectations, and power dynamics. And finally, it needs to be understood within specific social, economic, and political contexts. Sexual identity encompasses a person's self-identity, biological sex, gender identity, gender role behavior or expression, and sexual orientation. Biological sex, or the sex assigned/documented at birth, is the term used to denote chromosomal sexual development. So male XY or female XX external or internal genitalia, secondary sex characteristics, and hormonal states. Gender is not the same as biological sex or sexual orientation. They are distinct concepts. Gender identity is the inner sense a person has of being male, female, or non-binary, which may be the same as or different from the person's biological sex or sex assigned at birth. Gender expression is how a person presents themselves to the world, is often expressed on a continuum, and may or may not correspond to gender identity. Gender diverse is a term that represents a wide range of gender identities that may vary from expected developmental norms. It includes non-binary, genderqueer, and gender fluid identities. People who experience clinically significant distress or impairment because their biological sex or sex assigned at birth is contrary to their gender identity are diagnosed with gender dysphoria. It is important to note that not all transgender or gender diverse individuals experience gender dysphoria. Cisgender refers to a gender identity or role performance that matches society's expectations based on biological sex. For example, a woman who identifies cisgender would have a vagina and be considered a biological female and would identify as female. Transgender, frequently shortened to trans, is a term that describes a wide range of experiences or identities where gender identification and expression differ from societal expectations that are based on a person's biological sex. For example, a person born biologically male, so they have a penis and a scrotum, may identify as female. Gender binary, male or female identification, is not the only option. Gender fluid describes a person whose gender identification and behavior shift from time to time, whether within or outside of societal gender-based expectations. There is an emerging understanding that external genitalia do not always dictate gender identification or gender expression. Some people identify as non-binary and may prefer the gender-neutral pronouns they and their rather than him, her, or his, her. Sexual orientation refers to romantic, emotional, affectionate, or sexual attraction to other people. In general, gender identity is one's psychological self-identification, whereas sexual orientation is who one is attracted to physically, emotionally, and or romantically. Although there is possible fluidity and ongoing debate regarding the human sexuality spectrum, commonly identified sexual orientations include some of these on the slide. Heterosexual or straight refers to a person who is attracted to a person of the opposite gender. Gay, which can be used for males or females, or lesbian, which is generally females, refers to a person attracted to members of the same gender. Bisexual refers to a person who is attracted to both males and females. A bisexual relationship or encounter does not necessarily mean that a person is gay. Asexual refers to a person who lacks romantic or sexual attraction to anybody. And questioning refers to a person who is unsure of their sexual orientation. The methods by which people gain satisfaction through sexual stimulation are varied. Touches, smells, sights, sounds, feelings, thoughts, and fantasies can all contribute to sexual fulfillment in any form of expression chosen by people. There are many different types of sexual behavior. On a continuum, sexual behavior ranges from adaptive to maladaptive. Adaptive responses meet the following criteria. It needs to be between two consenting adults, mutually satisfying to both, not psychologically or physically harmful to either. It lacks in force or coercion. It's conducted in private. Maladaptive sexual responses are behaviors that do not meet one or more of the criteria for adaptive responses. Masturbation is a technique of sexual expression in which a person practices self-stimulation. Many myths and misinformation surround masturbation. Because of these myths, people might not masturbate if they feel guilty about it or believe self-stimulation is wrong. Masturbation is not dirty and will not lead to blindness or insanity, as some of the myths proclaim. The act of intercourse, or coitus or copulation, is the insertion of the penis into the partner's vagina, anus, or mouth. Orogenital stimulation, or oral sex, is stimulation of the genitals by the mouth and tongue. Cunnilingus is the term used to describe stimulation of the female genitals, and fellatio is the term used to describe stimulation of the male genitalia. Abstinence is not having sex. It is the most effective form of birth control, preventing pregnancy 100% of the time when practiced consistently. Abstinence also prevents the transmission of sexually transmitted diseases 100% of the time when practiced appropriately and consistently. Some alternative forms of sexual expression include voyeurism, which is the achievement of sexual arousal by looking at the body of someone other than one's sexual partner. Although voyeurism itself is not inherently wrong, some voyeurs develop complex means to spy on others that involve violations of privacy that are illegal. Sadism, machoism, sadomasochism all involve some type of abuse or humiliation to gain sexual pleasure. These types of sexual expression can be considered adaptive if they meet all the criteria that we talked about earlier in this slide. Pedophilia, the practice of adults gaining sexual fulfillment by performing sexual acts with children, unlike the other items on this list, depending on the circumstances, the other things may be considered adaptive sexual responses. However, pedophilia involves children who, by nature of their age and maturity, cannot consent to sexual activity. Pedophilia is wrong, illegal, and maladaptive in all cases. Many factors influence a person's sexuality and contribute to personal feelings regarding sexuality. The process of human development affects the psychosocial, emotional, and biological aspects of life, which in turn affect a person's sexuality. Biological sex is the only distinguishing trait present at conception. From birth onward, biological sex and gender influence behavior throughout life. The manner in which a society perceives sexuality influences the person. Every culture has its own norms regarding sexual identity and behavior. To some degree, culture dictates the choice of sexual partner, duration of sexual intercourse, methods of sexual stimulation, and sexual positions. In some cultures, women may be expected to merely tolerate sex. In others, the woman's participation is encouraged. Some people view organized religion as having a generally negative effect on the expression of sexuality. For example, in many religions, the concept of virginity came to be synonymous with purity, and sex became synonymous with sin. In addition, many forms of sexual expression other than male-female coitus are considered unnatural by some religions. As a result of the rigid regulations and negative connotation of sex dictated by some religious groups, a number of sexual dysfunctions can be related to a person's resulting guilt and anxiety. Healthy sexuality depends on freedom from guilt and anxiety. What one person believes is wrong may be perfectly natural and correct to another. Some people may feel that certain forms of sexual expression are bizarre, and the people who participate in them are perverted. People who should personally decide which aspects of sexual expression are comfortable for them. Modern lifestyles greatly affect sexuality and its expression. All adults are exposed to stress, and many are under considerable strain to perform and function in the workplace as well as at home. Varied responsibilities may place a time constraint on communication between a couple, as well as on the energy level and motivation for sexual satisfaction. Although some couples view sexual activity as a release from the stressors of everyday life, most place nurturing relationships and sexual expression far from the top of the list of things to do. Lifestyle variables can also influence the sexual expression of adolescents and young adults. Young people who receive accurate, direct information regarding sex and develop associated skills to protect themselves are less likely to engage in sexual behavior that involves multiple partners and increases the risk of STIs, unwanted pregnancy, HIV, and other unintended health outcomes. Pages 1368 to 1374 cover topics regarding menstruation, sexual function, and dysfunction, as well as STIs. These are topics that you will be covering later in your adult health courses, as well as family-centered nursing, so I'm not going to be covering them in this course. A healthy body, mind, and emotions are necessary for sexual wellness. A primary sexual dysfunction can affect a person's sexual expression. Similarly, any trauma or stress that interfere with a person's ability to perform daily functions will also affect the expression of sexuality. Illness is no exception. Diabetes mellitus is a hormonal disease in which an inadequate amount of insulin is secreted by the pancreas. Although almost all hormonal disorders affect sexuality in some way, diabetes is the most prevalent and well-known. Erectile dysfunction or impotence is a great concern among those with type 2 diabetes. Females with type 2 diabetes may also experience loss of capacity for orgasm. It's called orgasmic dysfunction. Difficulty experiencing arousal and loss of vaginal lubrication have also been reported. Females with diabetes are more prone to urinary tract infection or vaginal infections, which can cause discomfort during sex. Cardiovascular disease is prevalent in North America, and the sexual response cycle can greatly increase the demands on the heart and other structures. A person with cardiovascular disease may experience much anxiety over the effect the illness will have on sexuality and sexual functioning. The most significant difficulty a person diagnosed with hypertension faces regarding sexuality is that the medication used to control the disease frequently causes a change in sexual functioning. These sexual dysfunctions may be relieved by modifying the dose of the medication or switching to a different medication. The primary goal after a myocardial infarction or a heart attack is to allow the heart ample time to heal. Activities of daily living, including sexual activity, should be resumed gradually, and stressors such as overexertion, alcohol consumption, and emotional upheaval should be avoided. After a heart attack, sexual activity needs to be resumed gradually, anywhere from 3 weeks to 3 months after the actual heart attack. Joint diseases and disorders affect people of all ages. Pain, fatigue, stiffness, and loss of range of motion can accompany any of the dozens of known diseases of the joints. The disease itself does not affect sexual functioning, however, although the manifestations of it can cause discomfort and anxiety. Surgery is performed to remove diseased tissue and repair body organs, usually requiring an incision with resulting scars. The most devastating kinds of surgery are those used to remove cancerous tissue and surrounding structures. Patients are almost always distressed about a diagnosis of cancer and possible death. After surgery, patients need to adjust to major alterations in their bodies. Mastectomy is a surgical procedure to remove a breast and surrounding tissues. After such a surgery, the return to sexual functioning depends on many factors, such as support of the sexual or life partner, the value placed on the breast by either partner, and fear of discomfort during sexual activity. Allowing the patient time to grieve the loss of the uterus or breasts is appropriate and may help with long-term coping. An ostomy is a surgical opening placed on the outside of the body to allow the passage of secretions and elimination into a closed drainage bag. Grieving over the loss of natural means to eliminate waste, such as urine or feces, accompanies learning to live with an obvious artificial device. Many people are anxious as to how this apparatus will affect their sex lives and how accepting their partners will be of it. Odor and leakage concerns need to be addressed to increase comfort with the device. Spinal cord injuries almost always result in some type of degree of permanent disability. People with spinal cord injuries face multiple adaptations in their lifestyles, including those related to mobility, bowel and bladder control, sexual functioning, and role expectations. The extent of sexual response that remains after a spinal cord injury depends primarily on the level and extent of the injury. Ejaculation and orgasm are most likely to remain with low spinal injuries. Females are more likely to experience orgasm than males, but they more frequently report a lack of physical sensations during the excitement phase than men do. Many chronic illnesses are accompanied by constant pain, and a person with persistent pain may not desire any sexual contact. However, the desire for human warmth and contact does not cease because of pain. Altered or modified positions for intercourse are sometimes necessary. The mind plays a powerful role in sexuality. Any disruption of its functioning will no doubt cause some disturbance in sexual functioning. Even mild depression can affect desire and sexual functioning. At times, patients with mental illness act out in a sexual manner, such as touching themselves or removing their clothing at inappropriate times and places. Sometimes it is difficult for the partner of a patient who has developed a mental illness to continue the sexual relationship. Some medications have side effects that may affect sexual functioning. You will learn more about these in pharmacology. Recreational drugs, including cocaine, alcohol, and marijuana, are used by some to heighten the sexual experience. These drugs can have serious and even deadly side effects. While some use alcohol to release inhibitions and to increase sexual arousal and desire, heavy drinking can decrease libido and negatively affect sexual functioning. So as always, the first step of the nursing process is assessment. Part of your assessment will be obtaining a nursing history. As a rule, 3 general categories of patients should have sexual history recorded by the nurse. This would be any inpatient or outpatient receiving care for pregnancy, STIs, infertility, or contraception, any patient experiencing sexual dysfunction, or any patient whose illness will affect sexual functioning and behavior in any way. The comprehensive health history should include information regarding a patient's reproductive and sexual health. Depending on the circumstances in which the patient is receiving care, this can include asking about their reproductive history. So we're going to ask females about their date of menarche, or when they first got their period, their date of their last menstrual period, duration and length of flow in days, number of pregnancies, living children, miscarriages, abortions, method of birth control. We're going to ask males the number of children they have produced and the method of birth control that they use. We may ask about history of STIs or history of sexual dysfunction. Ask about their self-care behaviors, self-breast exams, self-testicular exams, when was their last pap smear or mammogram. Inquire about their sexual self-concept. This includes questions regarding sexual identities, sexual body image, sexual self-esteem, and sexual role performance. And then ask about any problems with sexual functioning. So we're not going to routinely do a physical exam of the reproductive and the genitourinary system on all of our patients. However, it will be necessary for patients that are undergoing the following circumstances. So it's going to be done as part of a routine physical exam or an annual gynecologic health exam, including a pap smear. If we suspect an STI, suspected pregnancy, we're going to do this type of physical assessment on a workup for infertility. Or if the patient notices an unusual lump, discharge, or appearance of the genital organs, if a patient comes in requesting birth control, or if they have any change in their urinary function. We need to make sure we keep the patient comfortable and respect the patient's privacy and modesty. That's going to be our primary consideration. Some female patients may be uncomfortable with a male examiner or vice versa for religious, cultural, or other reasons. The examiner can adapt such concerns, for example, by ensuring that a female nurse is in the room when a female patient is undergoing a pelvic exam by a male provider. Some patients who are transgender prefer to be seen by a provider who is known to the LGBTQIA+ community or provides transgender care specifically. Before a sexual-based issue is identified as a problem, carefully review the assessment data to determine whether the situation can be corrected by independent nursing interventions. Although many problems of sexuality experienced by a patient in a healthcare situation can be helped by nursing actions, some require the expertise of other specialties. For example, sexual function issues may include erectile failure or impotence, premature ejaculation, delayed ejaculation, inhibited sexual desire, orgasmic dysfunction, and pain with sex. Other sexual-based issues can be related to change in sexual patterns like loss of desire, increased desire, or a change in sexual expression. Nurses should value sexuality as an important component of who the patient is and how the patient identifies as a unique human. Specific patient outcomes to promote sexual health are identified on this slide. So in this case, our goals or our outcomes would be something like the patient will define individual sexuality, establish open patterns of communication with significant others, develop self-awareness and body awareness, describe responsible sexual health self-care practices and identifying appropriate resources, and practice responsible sexual expression. Specific patient outcomes depend on the nature of the patient's problem or concern. Expected outcomes should be patient-oriented, that is, something that the patient desires to do or has the ability to accomplish. So, for example, it is not enough to advise a method of birth control, rather the nurse needs to know which method the patient is motivated to use. It is impossible to address a patient's sexuality if trust has not been developed between you and the patient. To develop trust, project an objective, non-threatening, and non-judgmental attitude, and emphasize that the information the patient gives will be kept confidential. You need to be aware of your own behavior and verbal and nonverbal cues. Most nursing interventions pertaining to a patient's sexuality involves teaching to promote sexual health. Major goals of patient teaching involved affecting change in knowledge, attitude, or behavior. In some situations, patients need help defining or redefining their sexuality, and it's important to their lives. Offering information, dispelling fears, and providing positive reinforcement are some ways to help patients increase their knowledge about their bodies and sexual functioning. Part of teaching also includes correcting any sexual myths and promoting body awareness. Many people believe things about sex that they have heard from family or friends that are not true or not based on scientific data. Patients need to know how to gain satisfactory sexual experiences while behaving responsibly in their activities. Responsible sexuality encompasses sexual expression, prevention of unwanted pregnancy, prevention of STIs, and sex education. The form of sexual expression used by patients should not inflict unwanted harm on themselves or others. When sexual expression encroaches on the rights of others, it is neither healthy nor desirable. Sexual acts that violate another's rights are usually considered to be acts of aggression or hostility rather than stemming from sexual need or desire. Contraception is a process or technique for preventing pregnancy by means of a medication, device, or method that blocks or alters one or more of the processes of reproduction in such a way that sexual intercourse can occur without impregnation. The prevention of unwanted pregnancy must be a conscious decision. Anyone who is unprepared for pregnancy should refrain from intercourse or obtain a contraceptive method from a healthcare provider or from the pharmacy. Pages 1886 to 1892 cover several different types of contraception. This information is going to be covered in pharmacology and your family center nursing courses, so I'm not going to cover them here. The nurse can help patients cope with sexual concerns generated by diseases in their treatments. Offer anticipatory guidance and information to patients, stressing the importance of open communication with the patient's partner. Include the patient partner in teaching when appropriate. When indicated, start a discussion about possible sexual positions that can reduce pain during sex. Inform the patient that intercourse may be more comfortable if pain medicine is taken before beginning sexual activity. When teaching patients about medications, mention any sexual side effects that may occur to prevent anxiety and depression. Patients should alert the healthcare provider if these side effects occur because the drug dosage may be able to be modified or the drug changed. If patients are unaware of this, they may discontinue the medication on their own rather than sacrifice their sexual functioning. The health and well-being of lesbian, gay, bisexual, and transgender people has been made a priority by major federal health care facilities. Stigma and a range of other social and cultural factors affect the health of the LGBTQIA+ people, as well as the ability of the healthcare system and providers to care for them. Sexual behavior, cultural factors, disclosure of sexual orientation and/or gender identity, prejudice and discrimination, and concealed sexual identity each present unique health challenges to this population. Other issues that affect healthcare delivery to this population include the following. The public health infrastructure. There have been lots of efforts to research and address the healthcare needs of the LGBTQIA+ people, and they are hindered by inadequate infrastructure to support and fund population-specific initiatives. Access to quality healthcare. Financial and structural, personal and cultural barriers limit access to screening and preventive services and cause delay in care for acute conditions in this population. Health communication. Negative provider attitudes, lack of provider education regarding unique aspects of lesbian and gay health, and exclusion of same-sex partners in care planning seriously hamper therapeutic communication between members of the LGBTQIA+ community and those who provide care. Educational and community-based programs. Some government facilities, professional organizations, and healthcare organizations address healthcare issues of this community, but this population still relies heavily on self-created community-based programs to address their special healthcare requirements. A hospital experience or institutionalization puts a strain on a person's individuality and sexual health. Illness may diminish feelings of sexual desire, and the desire for sexual interaction can signal a patient's improving health. The nurse should provide anticipatory guidance because many patients may hesitate to request help for fear of being ridiculed. Box 46-4 on page 1893 discusses several different ways to advocate for your patient. Another thing to keep in mind is not all patients with sexual concern need intensive therapy. Some patients benefit greatly from simply having someone listen to their concerns. Voicing their concerns allows patients to put information into perspective and focus on what the problem is and how to solve it. When counseling patients, do not offer your own advice, because what is right for one person may be wrong for another. Adopt an objective, non-judgmental, empathetic, and receptive attitude to facilitate open communication with the patient. Abortion remains an issue that deeply divides people. When it comes to abortion counseling, you should examine what you believe, why you believe this, and how your beliefs are likely to influence your ability to counsel individuals and couples of childbearing age. Nurses encounter children, adolescents, women, and sometimes men who have experienced sexual abuse or rape. Clearly, nurses need to be alert to evidence of sexual abuse while taking a history and conducting physical examinations. Abuse crosses all socioeconomic and ethnic groups. Become familiar with your legal and clinical responsibilities when a victim is identified. The first priority is getting the victim to a safe environment and mobilizing support for the victim and family. Multiple parties may need therapy. Be familiar with local resources and make appropriate referrals. So the last area we're going to talk about is spirituality. Paying attention to the spiritual dimension of health and well-being is integral to the holistic person-centered care. Patients facing the losses and limits related to injury, disease, or aging begin to evaluate what is important in life and often ask the big questions like, is there a God or a transcendent being? Does life have meaning and purpose? National guidelines now mandate spiritual care. In 2016, the Healthcare Chaplaincy Network developed the most comprehensive evidence-based indicators that demonstrate the quality of spiritual care in healthcare in a move aimed to advancing spiritual support and meeting the needs of patients, their families, and healthcare institutions. According to Shelley and Fish, 3 spiritual needs underlie all religious traditions and are common to all people regardless of whether or not they belong to a particular religious tradition. These are the need for meaning and purpose, the need for love and relatedness, and the need for forgiveness. Nurses can assist patients to meet spiritual needs by offering a compassionate presence, assisting in the struggle to find meaning and purpose in the face of suffering, illness, and death, fostering relationships, either with a higher being or other people, that nurture the spirit, and facilitating the patient's expression of religious and spiritual beliefs and practices. Spirituality, faith, religion, and the influence of these elements on everyday living and health and illness are important concepts to understand when caring for patients. This slide kind of talks about some of the different definitions that can be used for these terms. Although some use the words spirituality, faith, and religion interchangeably, there are some distinctions, so we're going to talk about these and some other concepts more in depth. Spirituality is anything that pertains to a person's relationship with a non-material life force or higher power. While one person describes spirituality in terms of coming to know, love, and serve God, another speaks of transcending the limits of body and experiencing a universal energy. Aspects of spirituality are listed on this slide, and they include spirituality is experienced as a unifying force, life principle, and essence of being. It is expressed and experienced in and through connectedness through nature, the earth, the environment, and the cosmos. People express and experience spirituality in and through connectedness with other people. Spirituality shapes self, becoming, and is reflected in a person's being, knowing, and doing. And lastly, it permeates life, providing purpose, meaning, strength, and guidance, and shaping the journey. Faith generally refers to a confident belief in something for which there is no proof or material evidence. It can involve a person, idea, or thing, and is usually followed by an action related to the ideals or values of that belief. For example, if I have faith in my doctor, parish nurse, or healer, I am more likely to adhere to a prescribed regimen or a plan of care and to experience benefits. Similarly, patients who believe in a loving and all-powerful being who knows them and cares for them are often better able to cope with the suffering related to injury and illness. Faith is a term also used to describe a cultural or institutional religion, such as Judaism, Islam, or Confucianism. An atheist is a person who denies the existence of a higher power. An agnostic is one who holds that nothing can be known about the existence of a higher power. So technically, an atheist is someone who doesn't believe in a God, while an agnostic is somebody who doesn't believe it's possible to know for sure if a God exists. Religion can be defined as an organized system of beliefs about a higher power that often includes a set forms of worship, spiritual practice, and a code of conduct. Although it is impossible for nurses to be knowledgeable about all religions, we are better able to meet patients' spiritual needs when we understand their religious beliefs and practices. These can directly influence patients' response to illness and suffering, self-care practices such as diet and hygiene, birth and death rituals, biologic sex roles, spiritual practices, and moral codes. Nurses who are unfamiliar with a patient's religion can gain valuable knowledge by discussions with the patient and the patient's family and spiritual advisor. We will be talking about the beliefs of some of these religions in class. Never presume to know that a patient's religious beliefs or practices are just because you have learned about the patient's faith tradition. Many religious groups and people work out their own set of beliefs and practices, which may or may not be compatible with the tradition at large. Also, you should not interpret the fact that a patient does not belong to an organized religion to mean that the patient has no spiritual needs. A person may be deeply spiritual, yet not profess to belong to an organized religion. Hope is the ingredient in life responsible for a positive outlook, even in life's bleakest moments. It enables a person to both consider a future and to work actively to bring that future into being. Hope allows a person to embrace the reality of suffering without escaping from it, which is false hope, or being suffocated by it, which is despair, helplessness, or hopelessness. Earlier, we noted that people express and experience spirituality in and through connectedness with other people. There is a basic human need to love and be loved, and we cannot be spiritually whole, spiritually healthy, unless that need is met. Suffering is a specific state of distress that occurs when the intactness or integrity of that person is threatened or disrupted. It lasts until the threat is gone or integrity is restored. Box 47.1 on page 1914 discusses the tenets of suffering in very great detail. Among the many factors that can influence a person's spirituality, the most important are developmental considerations, family, ethnic background, formal religion, and life events. Because spirituality involves the non-material realm of being, a child must have developed some capacity for abstract thinking in order to understand the spiritual self. As the child matures, life experiences usually influence and mature the child's spiritual beliefs. With advancing years, the tendency to think about life after death prompts some people to re-examine and reaffirm their spiritual beliefs. A child's parents play a key role in the development of the child's spirituality. What parents explicitly teach a child about spirituality and religion is generally less important than what the child learns about spirituality, life, and self from the parent's behavior. Religious traditions differ among ethnic groups. There are clear distinctions between Eastern and Western spiritual traditions, as well as among those of individual ethnic groups such as Native Americans. Each of the major religious groups discussed earlier in this chapter shares several characteristics. There's a basis of authority or source of power. They have scripture or sacred word. There's an ethical code that defines right and wrong, a psychology and identities so that its adherents fit into a group and the world is defined by that religion. There are aspirations and expectations, and there are ideas about what follows death. Both positive and negative life experiences can influence spirituality, and they in turn are influenced by the meaning a person's spiritual beliefs attribute to them. For example, if two women who believe in a loving God both lose a child in a car accident, one may bitterly deny God's existence, whereas the other may spend more time in prayer asking God to help her. Similarly, a chain of successful life experiences may cause one person to assume success and experience no need for God, whereas for another it occasions deep gratitude and rejoicing for the same. Because a person's spirituality and religious beliefs can influence every aspect of being, an assessment of the patient's spirituality, including beliefs and practices, the effects of these beliefs on everyday living, spiritual distress, and spiritual needs, should be included in each comprehensive nursing history. So how do we go about assessing for spirituality? One simple guide is Anandaraha's and Haidt's HOPE acronym. H stands for hope, sources of hope, meaning, comfort, strength, peace, love, and connection. O, does the patient have an organized religion? P, what are your personal spirituality and practices? And then E, what are the effects of your beliefs, religion, spirituality on medical care and end-of-life issues? Because many patients find it difficult to talk about their spiritual beliefs and problems, also observe the patient's behavior for signs of spiritual distress. Family members may also be able to give you good information regarding this. So for example, if an adult child mentions that they have never seen their parents so depressed, this may be a spirituality issue that needs to be addressed. Significant behavioral observations include sudden changes in spiritual practices, maybe rejection, neglect, or fanatical devotion. Mood changes, so frequent crying, depression, apathy, anger. Sudden interest in spiritual matters, so reading more religious books or watching religious programs on television, or disturbed sleep patterns. If you observe these behaviors, you should follow up with appropriate interview questions. So this slide kind of describes some of the specific assessment areas that need to be addressed during a spiritual assessment. First one is spiritual beliefs. Are there particular spiritual or religious beliefs that are important to you? Have these beliefs changed recently? Is your illness challenging these beliefs? What about spiritual practices? Describe your usual spiritual practices and anything interfering with your ability to perform them. Can I help in any way to secure the aids necessary for practices? So do they need a prayer shawl, a Bible, crystals, beads, anything like that? What's the relation between spiritual beliefs and everyday living? Describe ways your spiritual beliefs affect your everyday living, your daily schedule, diet, hygiene, sense of self, and the world relationships. Is there any spiritual deficit or distress? Are your spiritual beliefs currently causing you any distress? What about their spiritual needs? In what ways can I and the other nurses help you meet your spiritual needs? Would you like me to contact your spiritual advisor or a hospital's pastoral care minister? Do they have a need for meaning or purpose? In what ways do your religious beliefs help or hinder you to understand your current situation and face it with peace and courage? What about need for love and relatedness? In what ways do your religious beliefs help or hinder you meet your need to be loved and to love and be loved? What about the need for forgiveness? In what ways do your religious beliefs help or hinder you to feel at peace? And what do we observe? What's our significant behavioral observations? Be alert to any sudden changes in spiritual practice, mood changes, sudden interest in spiritual matters, and sleep disturbances, any of which may point to unresolved spiritual needs. An assessment of a patient's spirituality and spiritual health may lead to identification of one or more actual or potential health problems and needs related to spirituality. Spiritual distress may be further specified as spiritual pain, alienation, anxiety, guilt, anger, loss, or despair. Common etiologies for spiritual distress include inability to reconcile a current life situation, so an illness, death of a loved one, divorce, with their spiritual beliefs, or a separation from religious community or support. So in the planning stage of the nursing process, we are going to develop goals or outcomes for whatever diagnosis or problem we decide to address. So in this example, let's use the nursing problem spiritual distress. So our goals are going to be for the patient to be able to explore the origin of spiritual beliefs and practices, identify factors in life that challenge their spiritual beliefs, explore alternatives to these challenges, identify spiritual supports, and report or demonstrate decreased spiritual distress after an intervention. A variety of interventions are available to help patients meet their spiritual needs. These interventions can be used in the home, hospital, or care center to help patients meet their spiritual needs. When implementing spiritual care, nurses work closely with other spiritual caregivers, including chaplains and pastoral care workers. Often the most important intervention is a well-timed referral to a professional spiritual caregiver. Before exploring spiritual care strategies, remind yourself of the importance of discussing spiritual concerns in a respectful manner and as directed by the patients. This slide offers some hints regarding professional boundaries. We want to keep the spiritual history patient-centered. We want to recognize that pastoral care professionals are the experts in this field and consult them as needed. Proselytizing which means trying to convert others to their own religion, is never acceptable in professional settings. Addressing any spiritual issues should not be coercive. More in-depth spiritual counseling should be under the direction of chaplains and other spiritual leaders. Praying with the patient should not be initiated by the nurse unless there's no pastoral care available and the patient requests it, or in situations in which the nurse and the patient have a long-standing relationship or share a similar belief system. The nurse can stand in silence as the patient prays in his or her tradition. The nurse can always make a referral to pastoral care for a chaplain-led prayer. A nurse's gift of supportive presence must underlie all other types of interventions to meet a patient's spiritual need. Supportive presence communicates value and respect. The best example of nursing presence would have been during the COVID-19 pandemic. Patients with COVID-19 who were admitted to the hospital were often allowed no visitors, and nurses helped facilitate communication with families using smartphones or social media. Too often, the only person present to a dying patient was a nurse newly valuing their ability to be present in a respectful, affirming way. Ways that a nurse can help a patient continue normal spiritual practices in an unfamiliar environment of the hospital or care center are listed on this slide. They include familiarizing the patient with the pastoral and religious services and materials available within the institution. Respect the patient's need for privacy or quiet during periods of prayer. Assist the patient to obtain devotional objects like prayer shawls or rosary beads or something like that, and protect them from loss or damage. Arrange for the patient wishing to receive the sacraments to do so. Attempt to meet the patient's religious dietary restrictions. And arrange for the patient's minister, priest, healer, or rabbi to visit if the patient wishes it to. If the patient has a conflict between spiritual beliefs and the proposed medical therapy, assist the patient in discussing this with the healthcare provider. Younger generations, such as millennials, are less religiously affiliated than ever before. The latest research shows that nearly 1 in 3 millennials do not belong to a faith community, and of those, only 10% are looking for one. One study noted that millennials are finding different organizations that meet their spiritual need. These organizations are focusing on 6 different themes to support this generation. These include community, personal transformation, social transformation, purpose finding, creativity, and accountability. Patients accustomed to regular periods of prayer but who feel too ill to pray as they would like, or who enjoy praying with others, may ask the nurse to pray with them or hope that the nurse will suggest this. Because there are many forms of prayer: quiet reflection, silent communication with God or a higher being, reading or recitation of formal prayers, silence or loud calling on God or a higher power, or conversation with God or a higher power, lamentations, or reading a holy book or other religious materials, the nurse can take the lead from the patient by asking, "How would you like us to pray?" With research suggesting links between prayer and physical, mental, and spiritual health, some have argued that healthcare professionals should pray for as well as with their patients. At the present time, no one is claiming that healthcare professionals are negligent if they fail to pray with patients. Depending on the nurse's beliefs, prayer may, however, be an effective intervention strategy. At the very least, nurses ought to be mediators of the spiritual resources patients and their families need. The patient who feels that the nurse is sensitive to spiritual needs and comfortable with their own spirituality may choose to share spiritual concerns with the nurse rather than with a religious counselor. A nurse who feels competent to counsel the patient may assist the patient to do some of the following. They may encourage the patient to articulate their spiritual beliefs, help them explore the origin of the patient's spiritual beliefs and practices, identify any life factors that challenge the patient's spiritual beliefs or cause spiritual distress, help explore alternatives given these challenges. So modify lifestyle, deny, modify, or reaffirm their beliefs, or develop new beliefs. And help the patient develop spiritual beliefs that meet needs for meaning and purpose, care and relatedness, and forgiveness. Not every nurse feels comfortable in the role of spiritual counselor. If you don't, suggest that the patient talk to a pastoral caregiver or a spiritual counselor. When a patient expresses a desire to speak to a spiritual counselor, help make the appropriate referral or offer to contact the patient's own spiritual advisor. Other options are to contact the healthcare facility's pastoral ministry department or use a referral list of clergy in the local community. If no representative of the patient's own religion can visit the hospital at a particular time, suggest a visit from the member of the clergy of another faith. The patient, depending on the situation and the immediacy of the need, may welcome such a suggestion. Both the patient and members of the patient's family may experience conflict between a particular spiritual belief or religious law and a proposed medical treatment or health option. The patient may want assistance when conferring with the spiritual advisor about a particular procedure. The nurse's role is to help the patient obtain the information needed to make an informed decision and to support the patient's decision-making. Because what the nurse says and the way it is said may powerfully influence the patient's decision, it is important to maintain objectivity. Conflicts that resist resolution may be referred to an ethics committee or a consult team. Okay, guys, we made it. This was a long one, but we made it through the psychosocial.